Dr. Juan Maria Rubio Lopez is a primary care physician who also he runs a public clinic in the south of Spain. He also has additional training in gerontology, and he's working on his PhD at the University of Jaén.
Good afternoon. I am going to show you a clinical case about the prescription about any medication that I am taking for a long patient, to show you a case of hallucination that for a person that was taking a treatment for Parkinson disease. For please next slide. I have no contact with the industry. I don't have any conflict of interest of declaration. Here we have the patient that I am going to present for you. He's a woman that has 86 years old. He weighs about 50 kilograms. He had a heart rate about 70 per minute, and his blood pressure was 130/60 when she was treated. His past medical history was about depression, Parkinson's disease, diabetes, type 2 diabetes, hypertension, osteoporosis, urinary incontinence, and he don't know any allergies. And she was a problem with tolerance about metformin. He was taking about 8 medication for general every day, for hypertension, for hypercholesterolemia, hyperide, for diabetes type 2, type 2 diabetes, vitamin B12, and for depression he was taking levodopa, carbidopa, and citalopram for depression. In the routinary laboratory test, he was about 9% of hemoglobin, glycosylated hemoglobin. He was about 120 grams per liter of hemoglobin. Creatinine was about 88 about milligrams, and his liver test was all of them normal. For please next slide. But there was a problem when the patient go to the neurologist, and the problem was because there were 2 neurologists implicated in this case. The first one, when the patient go to the room, have a prescription of gabapentin 300 milligrams per day. I don't know the reason for that prescription. It's very common to give gabapentin for many problems. I know in other case, pregabalin. It is no say why. It is very useful for many doctors to give a prescription for one visit to the rooms. So in this case, we were giving gabapentin. And for some past month, the patient go to another neurologist, and he stopped gabapentin but prescribed rosuvastatin 1 milligram per day as an adjunctive treatment for Parkinson's disease. It is probably to reduce the on-off phenomena that we were taking for the evolution of the Parkinson's disease. From rosuvastatin was added for treatment for Parkinson's disease. I am going to say you something about rosuvastatin. It is a irreversible inhibitor of monoamine oxidase B. He have a half-life for elimination about 3 hours, but MAO B inhibitor is longer. It was approved in Canada in 2006, and he was taking for 1.5 to 1 milligram per day maximum dose when added to levodopa, 1 milligram for maximum for when taking for monotherapy. Selegin was approved in 1990, which most expensive and similar efficacy. The next one, here you have the secondary effects of the patient.
Cualquier cosa. Veía gente rara, ladrones.
Pero eso es la verdad o una mentira.
Era verdad.
Lo que leía.
Eso es mentira.
¿Y cómo te diste cuenta que era mentira?
Cuando me he dado cuenta de que veo que no lo que sea. Con las pastillas, ¿no? Las pastillas me las tomo y bebo de mejor. ¿Y no ves nada? La otra noche que se le olvidó, problema. Algo. Vamos, que sufre, que vemos cosas que yo que sé, no ves, eso ni viene.
¿Y qué veías?
¿Qué veías, mamá? No, que por lo que veo, con lo que veía, porque era un disparate de cosas.
No, pero no pasa nada, estamos en confianza.
Veías ladrones. Ladrones, gente mala. Y vienen a por ella.
So when I saw this patient for my clinic, for my room, with the doctor, the doctor come to my room and asked me for the problem that he was taking for this patient. He has hallucination, and probably I don't refer it to for the new medication that he was taking. For I thought about it was probably a delirium for a defection for a constipation. I probably thought about partial compensation. I don't know. It's very difficult. It probably it will be of the progression of Parkinson's disease to dementia, or for Alzheimer's body dementia in the evolution of the progression of disease. For my initial response, to control hallucination, I prefer to give her quetiapine 25 milligrams per day. So probably in the first time, I don't think about it. Probably was about a secondary effect of rasalagine, but I thought I studied about that, and I thought that probably it could be about a secondary effect of rasalagine. So in this case, I prefer to stop them for this medication and to show what was the result of that stopping of this medication. So there was a problem with that, because the family thought about don't stop a medication for my mother if the neurologist have given to my mother, because you are primary care physician and they are neurologists, so probably they know more about this case than you. So it was a problem to talk about the family, but we can try it. So the problem was, which is better to treat this disease? Probably the best is the neurologist. So both the neurologists say the patient one time for every 6 months, or for each 3 or 5 months, but the primary care is more frequently, so can they monitor signs, the side effects, or any things or other things that can happen to this patient. So if the primary care get involved in this case, they can solve many problems that can appear. So my new working for diagnosis for the hallucination from rasalagine was a therapeutic plan that I have done. I stopped rasalagine. A few days later, the hallucination stopped, according with the pharmacodynamic of rasalagine. If you remember in the previous slides, you can multiplicate by 5 the half-life. In the next, I reviewed the patient with the doctor and expect the progression to Parkinson's disease. So to the joint-making decision in according to this patient, I stopped simvastatin, because you can have to a primary prevention of that, to stop glimepiride by the risk of hyperglycemia, and to control glucose and certified patient. I started sitagliptin 50 milligrams per day and added lorazepam 1.5 milligrams at night, which reduced nervous and improved her tremors. In this month, in March 2024, depression was stable, Parkinson's disease had stable, type 2 diabetes are acceptable. He has now a hemoglobin, glycosylated hemoglobin. His hypertension is controlled. He is now about 120 and 70. When he's sitting and standing, it's very important to know that the cause of syncope associated with Parkinson's disease, and if he has not urinary incontinence. Now he is taking 7 medication to control his disease, and the laboratory tests of urinary are okay, like the previous one. For the next one, the other thing that I have learned for this case is sometimes it's better to stop a medication to control any symptom than to add another one. Monitoring what happened here, if the patient have gone to the hospital to visit endocrine, for example, for a neurologist, a cardiologist, and control and see what are the new symptoms that are appear here, and think about relationing about the new medication that he has taken now. In neurologic disease, it's not very important to control glycosid hemoglobin. The treatment goals can depend of the quality of life, and the overall function is not the same. A patient with 70 years that are at home all the day, that a patient with 70 years that go to work 15 kilometers all the day. Family plays is another have learned for this case. Family is very important here with you are making a prescription for the patient, because they don't accept in many times that you can get down, put off any medication that he has taken for many years. But you have to show that it is not very important for the patient to take medication, because the objective is not the same like 20 years before. Preserving function and maintain mobility and appropriate physical activity is as important as medication to get a good quality of life.
I'm just going to show very quickly 2 slides, which we will send to all of the registrants in a PDF. I have to admit, I had not heard of rasalogene before Juan Maria submitted this case. It turned out it's used quite a bit in British Columbia, and although it's probably not any better than its predecessor drug, it's much more expensive. And I consulted a friend who's a leading expert, internationally recognized expert in Parkinson's disease. He sent me an email that explains his interpretation of when it may be a good idea to add a monoamine oxidase inhibitor, irreversible like these. And you will have this in a PDF, so I'm not going to spend more time on it now so that we can get on to questions. But for those of you who are interested, particularly in Parkinson's disease treatment, take a look at the message from Dr. Stossel, who gave me permission to share this with you. And now, Aaron, you can take over and handle. Thank you very much, Juan Maria.
Thanks. A wonderful presentation. And there's some interesting comments and questions that I'll get to. The first one that comes to mind, or that I see by 2 people, was their concern with the interaction between the rasalogene and the escitalopram. So did that come up in the discussion, the potential interaction and the harm associated with that?
Yes, I have known, I have a study about interaction of escitalopram and the rasalogene, because they have the same neurotransmitter, the way they can act. So I thought about to stop rasalogene, because they were the last medication that the patient have started taking. So in this way, I start doing that. How the patient improve, I stop here doing that. So in this way, I can think that it is very important to stop this medication escitalopram, because they were taking for many times and they have any more secondary effect than rasalogene.
Okay, great. The next question was about the B12 and why that was being used. And one of the other participants suggested, could it have been from B12 deficiency from metformin, perhaps?
I don't know about B12, because he was not eating many more for anything of desnutrition. And in this way, you can stop that. I thought it was about the taking for metformin, but it was not about metformin, because he was not taking that. So he was only taking sulfonylurea. So I thought that it was about the problem with the nutrition. It was not very important to stop that, because it had a very secondary effect.
And another question here about, where is it? The lorazepam. Was the intended duration to be long-term or short, or what was the assessment plan for the lorazepam?
Like he was taking for a quetiapine the family, or only the family, know about the effect of quetiapine, and to start that, to say how is they sedating him to make relax at night, you can add a low dose of lorazepam, are the first time with the more important thing to describe this about the risks of falls or anything that can happen to the patient.
And another question. So one of the participants said they'd heard from some colleagues that it may be best to taper and then discontinue some Parkinson drugs like amantadine. And do you have any comments on your experience with this?
You have some need to taper for medication for Parkinson disease. So if for hallucination, when you are taking high dose of Parkinson disease, probably you can estimate much your brain and can appear for a medicate for hallucination or appear for high dose of Parkinson disease. So in this way, because like the hallucination have stopped, I have done for that. If you take 3 medications, you have 3 problems of interaction with any of them. If you take one, you have 2 possibility of interaction of that.
Okay, great, thank you. And the final question, Tom and Juan Maria, someone's asking about the opportunities to adjust the medications for blood pressure. So they're asking, what is the goal? Could any of the medications for hypertension be decreased or stopped? And a comment about potentially the diuretic contributing to the incontinence.
Yes, but the goals of hypertension medication, it depends on the quality of life of the patient. It's not the same. I have said that if you have a patient, you have very, very helpful that go to gym, for example, or going to work. You have to improve his level of pressure. It's not the same of the patient that is palliative care with the same or with the same or year hours. So you have to first to think to start a medication with our patient is very important to quality of life. The goal that you have to propose with the patient and with the family, very important to talk about the family, what you are going to the goal of treatment. So in clinical guides, I thought about to start a medication for a patient in the last one about 115 and night.
Okay, thank you very much.
And another question about the most likely cause of death in advanced Parkinson's disease. So far as I know, it's probably aspiration and then pneumonia. And it's an important issue because drugs that block dopamine receptors are likely to impair swallowing. And perhaps anticholinergic drugs as well will impair swallowing. Anything that impairs swallowing, including sedative drugs like gabapentin or benzodiazepine or zopiclone. If the goal is to preserve life, those are always issues. And one final comment, Dr. Guillaume Granet, our colleague here, pointed out that metformin is known to cause vitamin B deficiency, not only chemical, but physiologically important vitamin B deficiency. And at least in Canada, most prescribers don't seem to be aware of that, so that this may have been a reason why vitamin B12 was being offered to this patient, but in the absence of metformin, it's at least another possible no longer necessary drug. So thank you. And thank you very much, Juan Maria, for a great presentation.
Yeah, excellent presentation. Thank you so much. And now we're going to switch gears and I'll introduce our next presenter. Sadie Quintal is an experienced clinical pharmacist who's now working with primary care clinicians on the northern part of Vancouver Island. And she's been working with us at the Therapeutics Initiative for a few months now. And we're so glad she had a case to present. And welcome, Sadie.
Thank you for the introduction. I'm really happy to be here today and looking forward to sharing. I'm going to jump right into things and talk to you about a woman who I have seen and I'm still seeing. She's approximately 40 years old, and she started out by asking her family doctor about the possibility of reducing medications to avoid gaining more weight and possibly even reduce weight. Her doctor agreed and started by tapering her off the gabapentin that she was taking and referred her to myself, the in-house primary care pharmacist, to discuss further medication trimming. Now, this woman, she's about 165 kilograms, approximately 5'7", right? That makes her BMI around 60. In terms of her labs, nothing was particularly remarkable to me, except I do note that her triglycerides were elevated. Her medical history is notable for sort of an extensive mental health history. She's got a diagnosis of borderline personality disorder. She has chronic depression, codeine use disorder, fetal alcohol spectrum disorder, and post-traumatic stress disorder. At our first appointment, we focused on trying to get through all of her medications to be clear about what she's taking and how she's taking them. And during this, I asked her to tell me sort of what medications she felt were the most important to her, which ones she thought really helped, and also to tell me which ones she felt weren't very helpful or that she thought might be causing side effects, right? And she was very clear that prazosin was really helpful with her nightmares from PTSD. She thought olanzapine was really helpful for her. It helped to steady her thoughts and just keep her mood stable. She thought that the oxybutynin was helpful for urinary frequency, really was happy with baclofen for neck pain. Now, when I asked her about acetazolamide, she actually was like, can I just stop that? But it turns out she didn't even know why she was taking it. For amitriptyline, she knew that it could cause weight gain, so wondered about maybe stopping that. And it was prescribed for sleep, but she wasn't really having any issues with sleeping lately. She's also on divalproex for mood. And if you remember, she does not have a diagnosis of bipolar. And she's not convinced that this really does anything for her. Now, you might be familiar with the sort of informed shared decision-making approach. Now, I'd like to suggest that when we're talking about deprescribing, you might take a different order of things. For example, in this case, I encourage the patient to share her experiences and preferences regarding medications before we compared options. And that's in order to prioritize discussing information relevant to her needs at the time. And this looked a little bit like this, right? I grabbed her preferences and values as we went through her medication list. I looked back at psychiatrist consults. You can see in 2019, a psychiatrist had suggested that we stop olanzapine to avoid metabolic adverse effects. And olanzapine is the most likely medication to cause weight gain, but she thinks it helps, right? She really feels like it's the medication that's helping her to remain steady and to control her thoughts. There are other medications that can contribute to weight gain. Right? Amitriptyline can cause weight gain, divalproex can cause weight gain, and she doesn't feel so strongly that those medications are helpful for her. And so in light of that, we had a discussion about the pros and cons of looking at stopping or reducing amitriptyline versus divalproex. Ultimately, we decided at this appointment to start with amitriptyline as the low-hanging fruit. It's very easy to taper off of, the pills can be split, and we pinned or deferred the divalproex changes until a later date. And I chatted with her at this appointment too about her acetazolamide. I explained to her that for her, this medication was prescribed for her benign intracranial hypertension. And I sort of explained why we thought it was important, and she agreed to continue taking that. And she didn't have any concerns once she knew what it was for. You may have noticed or not that she's also on salbutamol for asthma. We had a bit of a conversation, and I explained about the greenhouse gas emissions that are associated with salbutamol inhalers. We talked about other sort of dosage forms, other inhalers, and what the guidelines suggest are best practice for treating asthma nowadays. And after that discussion, she agreed to switch to a budesonide formoterol dry powder inhaler. So our second appointment was 4 months later. At this point, she had stopped her amitriptyline completely. She'd switched inhalers and was happy with it, no concerns. And as I said before, she's happy continuing with the acetazolamide. She did have some other concerns though. One, she wondered about her baclofen. She'd been taking that 4 times a day, and she'd started thinking that, she'd like to simplify her regimen and not have to have 4 dose spots in her blister packs, and wondered if we could change it to 3 times a day. She also was still concerned about her weight, right? She's definitely interested in trying to reduce the divalproex, but she's a little bit nervous about remaining steady, right? She doesn't want to cause any major fluctuations to her mood. And she's starting to, at this point, consider olanzapine, right? She knows that it can increase weight. And now she's starting to think that maybe she would be open to looking at alternatives to olanzapine, right? In light of that, we sat down and had a discussion about the pros and cons of stopping olanzapine versus divalproex. We'd only met once before at this point, and that was 4 months prior. So while olanzapine is the most likely to be causing weight gain, it's definitely associated with metabolic disturbances. And if you remember, she had elevated triglycerides already. I was a bit hesitant because I just didn't know her history very well, and what that unsteadiness or mood fluctuations might look like for her. Now, divalproex is also associated with weight gain. And so we had a chat, kind of weighed the pros and cons, and agreed at this appointment to start with just a reduction in the divalproex and to come back to a look at olanzapine and reconsidering something to substitute for it at our next visit. One sort of ongoing concern she had was about her weight. So at this appointment, we also discussed possible options to help assist in weight loss. Now, unfortunately, we don't have coverage for semaglutide in BC for weight loss, and she has no private health insurance and would not be able to afford that medication. So it's just not an option for her. However, the Canadian obesity guidelines do suggest that for people taking antipsychotics, they could consider using metformin to mitigate metabolic side effects. Now, my understanding of the evidence for metformin in weight loss is that it's pretty wishy-washy, but anecdotally, I have seen people try it and lose a substantial amount of weight for them. Whether that's specifically related to the medication or not is unclear. But after talking about it, she decided that she wanted to try taking metformin. So at this point, this is 7 months out from the first time we've met. It's our third visit. The metformin had not yet been started. Her family doctor hadn't written a prescription for it at this time. She's reduced her divalproex from 2,000 milligrams a day to 1,500 milligrams a day. And she says that she would rather not reduce the dose of that any further and wants to prioritize making a change to her olanzapine. And she really wants to talk about alternatives. And she really had no issues with reducing the baclofen down to 3 times a day from 4 times a day. No change to her neck pain was noticed. Right. This appointment was a little more in-depth. We had to have a discussion about her past history with antipsychotics and her response to therapy. So I started by asking her what she felt the antipsychotic did for her. And her answer was that it was for spinning thoughts and paranoia. It made her feel less fight or flight response, and she felt calmer. We talked about her past medications. She said she had tried aripiprazole, which she only knew as Abilify, but that it didn't work. She'd been on risperidone, but she had to go off of it because it made her milky. And she'd been on quetiapine in the past, but went off of it due to weight gain. This one she did say was effective. And in her past notes from a psychiatrist, they had suggested reducing or stopping olanzapine and replacing with a med with lower metabolic side effects, such as risperidone or aripiprazole, or possibly by optimizing the divalproex. We talked about all the different options. We looked at different medications that she might consider, but she ultimately decided she wanted to retry aripiprazole. She said that at the time when she tried it the first time, she was in a much less stable part of her life, and perhaps it didn't work just because of the situation and not because the medication was not effective. So we agreed to stop her olanzapine by tapering down and start aripiprazole and sort of cross taper up. Now, I note that it would potentially be possible to just stop olanzapine and not replace it, given that there's no clear indication of like psychosis or schizophrenia that would cause us to really need an antipsychotic. But she did not feel comfortable going off of these medications fully. So at this time, we're doing some sort of mitigation of harms by doing a switch to a different antipsychotic. And we talked a bit about the possible movement-related side effects related to aripiprazole so that she'd know what to look for. And because the metformin hadn't been started the last appointment she had with her doctor, we just made a note again that this is something she wanted to pursue. So our fourth appointment at 10 months, she has now completely stopped olanzapine and switched to aripiprazole 10 milligrams daily. And she was quite happy with that switch. Interestingly, though, she found that the aripiprazole was making her feel tired after taking it in the mornings, which is where it was put in her blister packs, and she asked it to be moved to nighttime. She had started on her metformin, only 500 milligrams daily, and she actually felt like that was going well and wanted to try increasing. I did not ask her at any point what her weight was. I didn't feel like it was necessary at this time. Now, there's a couple other things she mentioned to me at this appointment, and that's that she was experiencing side effects from some medications which previously she had been happy with and hadn't. So the clonidine, for example, she now was feeling like it made her tired after she took it. And the oxybutynin, which previously she had been quite satisfied with, now she's finding herself feeling paranoid or that it's hard to speak after those doses. And I don't know if this is the case, but I have to wonder if perhaps she was just so wiped by the olanzapine that she didn't notice or didn't have the ability to notice the side effects of all of these other medications, which objectively one might notice feeling sort of sedated or drowsy or having anticholinergic symptoms like dry mouth after taking, right? So at the end of that appointment, or during that appointment rather, we talked about a prioritization for oxybutynin versus clonidine. Now, you may have noticed by now, but my mantra tends to be one thing at a time and small changes rather than doing too many things at once. So we talked about oxybutynin and clonidine, what each of them was for, and she decided she wanted to try reducing the oxybutynin to 5 milligrams twice a day from 10 milligrams twice a day. As I mentioned before, she wanted to increase the metformin. We moved her aripiprazole to bedtime, and we deferred reassessing her clonidine to a later date. So at this point, we've discontinued 4 different medications. So her olanzapine has been stopped, amitriptyline, gabapentin, salbutamol. Her divalproex has been reduced, baclofen has been reduced, and oxybutynin have been reduced. We have started 3 medications, aripiprazole, metformin, and Symbicort, which is the budesonide and formoterol dry powder inhaler. And we have a plan for the future to reassess her clonidine. So I really feel like I've learned a lot through this case. And it isn't even finished yet because we still have plans to see one another in the future and continue to look at making changes in order to improve the way she's experiencing her life. And I think that the most important thing here was to let her lead, even if it's not the order in which I would make changes, right? Because this prioritizes the development of a trusting relationship, right? At the beginning of the first time we met, she wasn't interested in changing her olanzapine at all, right? But over the course of time with education and a supportive relationship, she kind of came to that on her own, right? And we've managed to stop 4 different medications, 3 of which were highly anticholinergic. So I think that that's like a great way that we could work together hand in hand. Also, we've learned that, shared decision-making is a non-linear journey. Life does go on outside of the clinic, right? Both for the patient and for the provider. So we had intended to meet again prior to this presentation. I was hoping to have seen her for a 5th appointment, but she wasn't able to make it. Now, I learned through our clinic that she's having some housing difficulties and had been moved into a transition home temporarily due to an altercation in her home. And I can just imagine, right? Right now, making changes to her medication is probably not the priority. We'll connect again when she's ready. And in terms of future opportunities, we're so lucky to be working in a team-based care setting, right? We have access to the clinic to a dietitian, to mental health support, to social workers. And I think, especially after having gone back and looked at this case in order to prepare it for presentation, that we really could offer some more services and support to this woman that could really enhance her life and her care. Right? And I really look forward to hearing any questions you might have. Thanks so much for joining me to hear about this case.
That was wonderful, Sadie. And there's lots of questions and comments, so we'll get started. I just wanted to echo a comment someone made. Someone said, I really love how you demonstrated the relationship, respect, and centering on the person's values and beliefs. That shared decision-making approach was wonderful. And I really liked the way you organized your slides, and at the end with that graphic showed what stopped, reduced, changed. I might steal that idea for other webinars. So let's start with the questions. One simple one, or maybe it's not so simple, is your assessments were every 3 months. Was there a particular reason for that, or is that the way your clinic is structured in terms of booking appointments?
No, absolutely not. It just so happened that at this clinic, her family doctor is quite busy. And because of the complexity of her history and medications, I would make a recommendation. I would send that along to the doctor. I'd request her to book an appointment with her family physician to review the recommendations together, because we don't have a time for like a care discussion, right? Necessarily with the doctor, because we don't often get a chance to sit together and discuss. And so it just took time for the changes to be implemented, for logistical reasons.
Great, thanks. More questions coming in, so my spot is being bumped. So a comment and a question. I think the decision to deprescribe becomes much more challenging if more than one med is started at around the same time. So in the case of the divalproex and the olanzapine, how can you be sure that the divalproex isn't doing anything?
I mean, I can't be sure of anything. I just went by what her thoughts were, right? She didn't feel like the divalproex was doing anything. And she does not have a diagnosis of bipolar. I looked back through her psychiatrist's notes. And so, just weighing the pros and cons of each, she ultimately felt like the olanzapine did more for her. So that's why we prioritize the divalproex.
Fair enough. And like you're so correct. Sometimes there's no way to know, but you use other pieces of information to dictate how you're going to proceed. This is more of a high-level philosophical question. Is this level of polypharmacy evidence-based medicine? Do we understand the multiple levels of interactions amongst all of these medications? Are they studied individually only or in combination? So I don't know if you had any comments about that statement.
I would say this is probably like the poster child for the absence of evidence-based medicine.
Yeah, and there's on a related note, there's an interesting paper I read several years ago about, I think it was a hypothetical scenario where someone said if you had the typical adult person that had multiple comorbidities, and if they followed every single clinical practice guideline for each of their comorbidities, what would be the pill burden? What would be the cost of adhering to those guidelines? And, it just climbs and climbs and climbs for a number of meds and associated risks. So I guess that sort of relates to the question or comment. So quite a complicated situation with atypical antipsychotic medications in the background of intracranial hypertension. Is it possible that the antipsychotic medications could worsen the intracranial hypertension and potentially lead to prescribing cascade, i.e. the acetazolamide? Was that ever considered, or do you have any thoughts on that now?
When we first met, just now like almost a year, dive into intracranial hypertension to see, if any of the medications could be contributing or what the deal was. But I didn't really have a chance to dig into that further. The chart was so long and extensive. So we decided I just focused my energies on what I could affect change on for now. But I think that's a great question and something I'd love to look into more.
And what about bariatric surgery? Was that ever considered or talked about with this patient?
Yeah, I believe it had been noted in her chart, but it wasn't something that she wanted to pursue at the time. I didn't discuss it with her, but I believe I read something about it in there.
Here's an interesting question. We know antipsychotics often cause weight gain, but does stopping them cause weight loss? This person's asking, does anyone have any experience or comments on this in patients that they've dealt with?
I don't have a comment for myself. I haven't seen enough people stop them to really know. Maybe Tom and his experience has, but I don't have an answer to that.
This idea that antipsychotics cause weight gain, but if you stop them for some reason, would you expect that the weight to come down, or?
I don't, well, as a general internist, I would expect it probably won't. It's the most you'd accomplish would be to avoid gaining even more. But also, if you're worried about hyperglycemia and various other adverse effects of the drugs, one would want to do it. And I think one of the interesting things about this case is that it was the patient who approached the doctor who then referred the case to Sadie, and that deals with one of the questions in the chat about where do the requests come from. It's wonderful that this woman did start raising questions herself.
Here's a question. Is it a good idea to combine more than one antidepressant with an antipsychotic, considering all of her medications, particularly because of drug-to-drug interactions that may be causing some of the symptoms she's experiencing? Any comments on that?
Yeah, I mean, I think that's a great question, and really the whole, like, underscores the whole role of my job as a pharmacist. And coming into a patient like this who's already on so many things, sort of all we can do is make slow, steady changes and sort of see how she feels with regards to trying to undo some of that. But I can only imagine that, you know, many of the social factors of her life, you know, maybe being unhoused at times, maybe having difficulties with family or difficulties in school, and added in an effect to not destabilize appropriate, I would argue, but promising. But I think where we are now, it's probably just so many things have been added on that are no longer necessary.
Let's see. If a patient's goals or preferences is to stop medications, how do you respect their goals, but also keep in mind that the drug may be necessary? Tough, but very interesting question.
Yeah, I find that a lot, actually. I live in an area where a few of the clinics that I work in have a large population of people who are not interested in taking medication for anything. And I think education is the most important part. So often I see people, and the entire thing we do all appointment is to go over what their medications are being used for, what the rationale is, and how that applies to them. And then they can make a decision regarding whether they think that's appropriate. You know, is it a statin post-heart attack? But then they go home and they read that statins are bad and no one should take them, right? Or is it these psychiatric medications? So I think, or in this case, the acetazolamide for the benign intracranial hypertension. Once education is provided, I think then people have the ability to make a decision. And, you know, I tell people this all the time, that like, you're in control of your own health and you get to make your own health decisions, but it's important to have all the information.
Absolutely. And I tend to agree. I don't see patients anymore, but you know, family and friends are often asking me. And to me, I really question what my understanding of necessary or this medication is a must is. Is it truly absolutely necessary? And isn't it up to the patient? When I explain to people what the likelihood of benefit and harm is for medications, and I give two different people the same information, they'll both make exactly opposite decisions with the same information. So it tells me something about what I think is necessary is going to be potentially different for different people. So, you know, maybe we should rethink what necessary means. Probably one more question and then we'll wrap up. One question about anticholinergic burden, and I apologize to everyone, I won't get to all the questions, there's just so many. But with the anticholinergic burden at her age, are there any other predictors for cognitive dysfunction? And how do you approach this in this case or in other patients, Sadie, about this volume of anticholinergic burden and its impact on cognitive ability?
Yeah, so I did recently come across a tool, which I haven't dug into, but it was like a Glasgow antipsychotic burden scale, basically like a patient assessment tool where you would ask a series of questions to try to determine the anticholinergic burden of medications. And I had meant to sort of read into that, check if it was validated, and then possibly use that in cases like this for my practice to help people to see, oh, all of these things that you might be experiencing could be due to these medications. And we can have this as a baseline and see if those change, if we make changes or reduce those medications. But I didn't use that tool here. I'd say probably it's just clinical experience and like sort of the knowledge of which medications are more anticholinergic than others.
Absolutely. interesting Cochrane review that was updated on anticholinergic burden and the risk of dementia and cognitive dysfunction. And it talks about the consistency in the evidence that it's not only how many drugs, but duration of exposure. And so in terms of reducing the burden, there's so many potential opportunities. If you can't stop the med, then lower the cumulative burden by lowering to the lowest effective dose for as many as possible. And then, like you said, using your notes from previous meetings to monitor any changes accordingly. So thank you to everyone that submitted comments or questions. Again, I apologize for not getting through them.
For those of you who are in British Columbia or close, our course that's advertised there on Saturday, October 19th is going to be very good this year in Vancouver. And I'm in the preliminary stages of planning a relatively sophisticated workshop on deprescribing. Thank you, everybody, for attending.